So before I go, I wanted to highlight this. This is would be our plan today evening. The cases to be discussed will encompasses three broad groups of tumors. One is the adult diffuse gliomas, ependymal tumors, and the primitive embryonal tumors. What you'll encounter today will be a stereotypic cases. Only this thing to make you well versed with the major molecular group of each of these broad family of tumors. Not to think too much, just to make averse and well versed with this so that you should be easy. I understand these CNS tumors are extremely uncommon. They're less than 1% of all human malignancies. So you need not be scared of this thing. In real practice, in reality, you might encounter very rarely or uncommon. So just enjoy this slide session, and to make you aware of this, whatever, in case if it is new features or new findings for you or new things for you, just learn and get acquainted with the terminology. And we'll be happy if you have any questions, you post it in the chat box, we try to address. So before we go into the cases, I just wanted to highlight, I know this has all been covered in the previous talks in various talks of neuro-oncopathology. What you want to understand is currently we are following the 5th edition of CNS tumor classification. In fact, this is the 5th edition, but there are 6 different versions of books for the WHO. The 5th book was in fact an updated 4th edition, and now the 6th one is actually the true 5th edition. You can say that earlier the classification used to be based on histology only. They used to be called as histological classification. Now the current classification is histomolecular classification. This is the big thing you should understand. The WHO classification is based on integrating histology and molecular markers. So probably only by histology you will not be able to diagnose an entity. You need to incorporate the molecular findings. Today in our cases, how we can get the information of this molecular marker by immunohistochemistry, we will learn. So a few things about the current classification. This is in the lines of 2016, that's the updated version of this, and it has incorporated all the recommendations by C-Impact now. So there is, in this classification, there is a movement more towards incorporation about the molecular features into the CNS classification. There are new chapters on the genetic tumor syndromes. There are entities like NOS and NEC categories have been retained. I hope you'll be knowing what are NOS and NEC. Probably in the case-based discussion, we can elaborate further on that. So these are the basic overall groups of the tumors in the current classification. What we are going to touch today is the first family group of gliomas and the embryonal tumor. The gliomas is a big family of tumors. Only a subset of the gliomas like adult diffuse gliomas and ependymal tumors will cover. So if you have to just recap about the classification of the CNS tumors in of this current 2021 classification, the gliomas, gliolural tumors, and neuronal tumors are all clubbed in one big family of tumors, in which one group is adult type of diffuse glioma. The second group is pediatric type of diffuse low-grade gliomas. The third group is pediatric type of diffuse high-grade gliomas, and the fourth is circumscribed astrocytic gliomas. And the final group, what you can say, is glioneuronal and neuronal group. These are the major 5 groups which include under this family of gliomas, glioneuronal tumors, and neuronal tumors, which have different other smaller family groups of adult type diffuse, pediatric type of tumors. Now, today in our edition, we'll see about the adult type of diffuse gliomas. So, for ependymomas, you have this classification of this is supratentorial ependymoma, posterior ependymoma, spinal ependymoma. Each of these groups are divided into supratentorial different molecular groups, which you will see. The supratentorial 2 major groups is ZFTA fusion positive, and second group is YAP fusion positive. For posterior fossa group, there is no name to it. It is group A, that is group B type, PFA and PFB. And spinal ependymoma is based on the histological vixopapillary subependymoma and the new entity which is anemic amplified. So today we are going to cover the supratentorial posterior fossa group. Embryonal tumor, as you know, all of them, like the most commonest is medulloblastoma. Non-medulloblastoma tumors are the other spectrum, ATRT, the stereotypical teratoid rhabdoid tumor. Repliform neuroepithelial tumor is crinoid. Embryonal tumor with multi-layered rosettes. There are uncommon tumors of CNS neuroblastoma, CNS tumor with BCOR internal tandem duplication, and CNS tumor, CNS embryonal tumor, NOS. Of these, atypical teratoid rhabdoid tumors and embryonal tumor with multi-layered rosettes, what you call as ETMR, are molecularly defined, at least in variant alteration defined. The rest of the tumors are based on certain amount of methylation and certain combination of alteration. These two tumors can be identified in immunohistochemistry, which we'll cover today. Few things on the tumor grading. There is a chain paradigm shift in the Cns tumor grading. The no more it is graded by the Roman, it is graded by Arabic numericals. That is just like other other tumors elsewhere. It is graded by English Arabic numericals as 1, 2, 3, 4, and the range of grades has been retained. The grading was considered an intratumoral grading. It is not a distinct entity anymore. Like astrocytoma is one group, and in the intra-astrocytic tumors, you have 2, 3, 4. So the clinicopathological grading, there are some things like, when you'll see medulloblastoma, it is always grade 4. It is no more like in the further grading. That's called clinicopathological grading. And some of the tumors, you have molecular features added to call histological molecular grading, which we'll see some cases here. So diffuse adult type gliomas, there are only 3 major groups you want to understand. One is astrocytoma IDH mutant, oligodendroglioma IDH mutant and 1p19 co-deleted. And the third group is, which is not fitting into these things, that all the rest of the tumors are classified as glioblastoma. What is to be understood here is there are only 3 broad groups of adult type of diffuse gliomas. The gradings are inside the each tumor entity, like astrocytoma IDH mutant is one group. Within the tumor, you have grade 2, 3, and 4. Oligodendroglioma is one group. Within the tumor group, you have grade 2 and 3. The glioblastoma is only one tumor, that is with grade 4. So you need to understand here, glioblastoma term is no more used for IDH mutant tumors. It should be called as astrocytoma IDH mutant tumor, followed by suffixing with the grade. So just to remind you, there is no adult IDH wild type astrocytoma that is grade 2 or grade 3 tumor. So when you call adult type IDH wild type tumor, it is classified as glioblastoma. So this is the conceptual evolution from histology to histogenomics. So you need to incorporate the genomic knowledge into it. So what you understand with this is, most important is you need to know whether any diffuse glioma is IDH mutant or not. Okay. With that, we'll start with the cases. Do you have anybody has any questions here? Like, did not understand any aspect of it? Review, we just can clarify in one line. Pooja, are there any questions?
No, sir, no questions.
Okay. Then maybe we'll go to the first case.
Yeah. So Dr. Anita can take up the first case?
Yes. So case 1, it's a 28-year-old female with intermittent headache and motor speech difficulties and seizures 2 years back, and no sensory motor deficits. MRI shows a lesion in the left frontal lobe extending into the insular cortex and temporal lobe, immediately abutting the lentiform nucleus. And
So,
measuring 70 to 5.
Anita, like, what do you infer from this? We'll go back to the history. So what do you infer? If you sum it up, the young 28-year-old lady. So what does the age signify here? Relevance here? Anita, we are not hearing you.
Sir.
So let me go back to the slide first, why we are talking about the age. What do you see here? What are the broad spectrum group of the gliomas here? One is
Adult type
diffuse glioma. The other one is pediatric type. Yeah. So is there any different broad groups? One is adult type diffuse, the rest are pediatric type and circumscribed glioma. So first thing, when you see the age, of course, the adult type and pediatric type is not based on the exact age of the presentation. It is a molecular basis of it. But usually when you're seeing a 28-year-old, you expect them to be of adult type of diffuse glioma. So our approach is, first, when you are seeing the history, it should cross in our mind that first let's deal with these type of tumors. Only if we can't classify based on this tumor, probably we go into the other spectrum. That is why it is important to know the history, what you are seeing now. So 28-year-old female. So probably we are dealing with some adult type of tumor. Okay. And what does intermittent headache and motor speech difficulties, seizures for 2 years? The history is almost like 2 years. What does it signify here?
Tumor.
So one Caesar is, yeah, tumor, which is there for relatively some tumor or any kind of mass lesion which is involved in the gray matter. So when Caesars are coming, it is involved cerebral cortex involvement is there.
Yes.
And at least we have in history, at least the presentation wise, at least 2 years of history. When you say 2 years of history, will you consider this as an acute presentation or what kind of presentation?
It's not acute, it is.
It is not an acute presentation. So it is probably some kind of a longish history type of presentation, which has got based on this some problem with the cerebral cortex,
Yes.
right?
Yes.
So what does the radiology signify?
Frontal lobe lesion.
So when you read first line is ill-defined, what does it mean?
It is not circumscribed.
Yeah. So if you go back to your classification, you have got one group of tumor as circumscribed glial tumors, right?
Yes.
If you go back, you remember?
Yes.
Should I go back? What is this? Circumscribed astrocytic glial. When something in CNS tumors, when something is called diffuse means diffusely infiltrating, it is not well defined. It's ill-defined. So from the radiology, whenever being a pathologist, whenever you're seeing the radiological findings, your first goal to know, is it a very well-defined or well-demarcated or well-circumscribed, or is it like ill-circumscribed, ill-defined, or very diffuse disease?